Good morning, friends. Welcome to our next learning session. And today I am going to talk about typhoid fever, also called enteric fever. Typhoid fever is caused by a bacteria which is rod shaped and which is gram negative. This bacteria enters our body through contaminated food or water or ice cream. Through these it enters the body by our eating, passes into the intestines and then multiplies and causes the problem. The important clinical features of this disease are: there is a fever which is quite high, which is remittent fever. It is neither continuous nor intermittent fever. The fever doesn't become normal through 24 hours, but it does fall by more than 1 degree, and that is why we call it a remittent fever. Now let me give you an example. On first day, the highest fever was 101 degree Fahrenheit. Then it came down to 100 degree Fahrenheit, and next day it goes to 101.5 degree Fahrenheit, and again it comes down to about 100.2 degrees, and then third day it becomes 102 degrees. Like this, each day the rise in fever goes on increasing. This is just like you are climbing a stair. On first up, you go to the second step and then come half step down, then again go 1.5 step up and then come half step down. So this type of fever is called a step ladder pattern rise in fever. This is typical of typhoid fever. The patient also has relative bradycardia. What is relative bradycardia? Friends, when we get fever, our heart has to work more to give blood to all parts of the body, and also to get rid of heat which is being generated in the body, and therefore the heart rate increases. So this is in proportion to the temperature we are talking about. For every 1 degree rise in temperature, there must be at least 10 beats rise in the pulse rate, but it doesn't happen. The pulse remains slow whereas the temperature is high, and this is also an important feature of typhoid fever, relative bradycardia. Then what more can happen is, towards the end of first week, the patient develops certain rash over the body, that is the lower part of the chest and upper part of the abdomen. These are small 1 to 2 millimeter size reddish spots which are not raised above the and these are called rose spots. This is also a typical feature of typhoid fever, rose spots. So I said relative bradycardia, I said step ladder pattern, and I said rose spots. These are the typical things. Unfortunately, we do not see rose spots there commonly. Usually it is described in textbooks as about 30% patients develop rose spots, but in our country, due to the color of the skin, we fail to detect many times the rose spots. But bradycardia and step ladder pattern can be noted, but there also difficulty comes when the patient comes to you. He has been given some antipyretics, and that changes the pattern of fever. And naturally, you agree with me, you cannot just keep waiting for the pattern of fever to develop before giving treatment to the patient, because patient needs immediate treatment. In the second week, there comes the very important feature that becomes splenomegaly. Spleen becomes palpable below the castle margin, and one should carefully look for this thing. Liver also becomes enlarged, and by the third week, the two important complications occur. That is the bleeding from the gastrointestinal tract, coming in the form of vomitus containing blood, and also other important complication is the perforation of intestine. Intestinal perforation can be very dangerous and it can cause death of the patient. Therefore, must be kept in mind. So after having learnt this much about typhoid fever, then what to do? I was to treat it. I got all the tests repeated. I got the test which was even done before also. I repeated again because the fever was not responding. And after having done so, I found that the viral test is still positive. The culture is negative, blood culture as well as the urine culture was negative, and the malaria parasite was negative. So the diagnosis was, of course, typhoid fever. I therefore thought of starting intravenous medicine. This is a cephalosporin. I chose Monosef 2 gram twice daily. As I said before also, I didn't want to take chance. Patient has been shuttling from one to the other place. So I gave him 2 grams of Monosef intravenously, diluted of course in 20 ml of normal saline, and injected. Still it caused pain to the patient as the medicine will go in. It is a known side effect of the medicine. After about 6 days of this treatment, the fever did not respond. Then I came to the old medicines. I started Furoxon and the Septran, that is the combination of sulfa with trimethoprim. And after another 7 days, the patient's fever started coming down and finally became normal. He remained under my care for about 2 months and his fever remained normal. So friends, this was a very interesting case where I learnt this thing, that how we should manage. In another case which I remember, a friend come patient who was working with DDA and used to come to me for common problems. He complained of that his wife had got pain abdomen, and before that she had fever, and these were the type of people who would not bother much about these illnesses. So suddenly she started having severe pain in the tummy. She was taken to the hospital, and as was expected, there was perforation of the intestines. This fever was the actual typhoid fever which was ignored by them, and ultimately when the patient developed perforation, they rushed to the hospital. Patient was saved by doing the surgery, otherwise it could be a very fatal incident. I am reminded of another patient who came to us from Old Delhi. He was very heavyweight person, very overweight I would say, and he had been given chloromycin, but he did not respond. So when we looked at the case, considering his weight, we raised the dose of chloromycin and he started responding. So dose has to be given weight for weight, and this feature cannot be overlooked. The patient responded. In another case, a female who was having her first baby developed a fever which did not disappear after her delivery. I asked the gynecologist to whom I had referred the case that what she is thinking about. She did not know about it. She said that I have got her test done, urine is normal, and the uterus and cervix are all normal, there is no problem. I point blank asked her, then why you are keeping the patient in the? That means you do not know the diagnosis, because whatever you know, that is normal. Then you have no right to keep the patient, because it is, the bill has to be paid by the patient, and the patient has the right to ask you. She agreed with me, and I asked her to discharge the patient. Patient came home, and since I had referred the patient, it was my responsibility to treat the patient. I started chloromycin straightforward in appropriate dosages, and patient within 3 days fever came down, and by 6th or 7th days the patient became perfectly normal. So friends, remember what I have told you, that fever to start with has a relative bradycardia. Fever rises in a step-ladder pattern. At no point the fever becomes normal. That means it is a remittent fever. And each day the fever increases from the upward from the previous day. That is the step-ladder type of pattern. And by the end of the first week, look carefully for the rose spots in the area of lower chest and upper abdomen, and look for the spleen. Palpate the spleen. Turn the patient to the right side, we say semi-prone position of the body, and then try to palpate using your both hands. Push with your left hand the area of spleen forward, and with the other hand fingers below the castor margins try to feel the spleen. That way you are very likely to get a spleen, and that is a very important mark. So friends, that's all for today, and we of course will meet with another interesting case next time. Thank you very much.